Cardiology Update viewers and listeners. I'm Chadi Alraies from Detroit Medical Center in Detroit, Michigan. Today, I'm really privileged to talk about one of the Headline sessions that presented at ESC 2023. The headline presentation was called the BUDAPEST CRT, and this is an upgrade and was update CRT resynchronization therapy in patient with heart failure with RV pacing. Joining me with the principal investigator, Professor Bela Merkely, who is the principal investigator of the trial. Dr. Merkely, thanks for being with us.
Thank you.
So, Dr. Merkely, tell us about the rationale of the study and what's the main hypothesis.
So approximately 1 million conventional pacemaker or ICDs are implanted each year worldwide. Nearly 30% of these patients develop left ventricular systolic dysfunction due to intraventricular dysynchrony induced by right ventricular pacing, can lead to heart failure, hospitalization, and associated adverse clinical outcomes. In patients with HFrEF, prior implanted a pacemaker or ICD, the potential benefit of an upgrade to CRT, where an extra left ventricular lead is implanted to the coronary sinus side branch, have not been established. And due to the lack of data regarding hard outcomes from large randomized controlled trials, the class and level of recommendations for cardiac resynchronization therapy upgrade have been modified several times over the past decade in ESC, ACC, AJ, HRS guideline, showing an unmet need for more robust evidence. Moreover, the indicated upgrade procedures are frequently not performed or deferred to a later undetermined date in over 60% of the candidates. Budapest CRT Upgrade was the first trial powered to hard endpoints on efficacy and safety of CRT upgrade versus ICD alone in HFrEF patient with intermittent or permanent pacing.
Interesting. So this is a very good and excellent landmark, as you mentioned, because we see this problem all the time, and preventing these patients from having RV failure down the line is crucial. So let's move on to the next section, which is the design of the trial.
So the Budapest CRT Upgrade is a multi-center, randomized controlled investigator-initiated trial testing the hypothesis that CRT upgrade compared to ICD only would be associated with improved clinical outcomes. The key inclusion criteria are HFrEF patients with a prior pacemaker or ICD, right ventricular pacing more than 20%, paced QRS complex wider than or equal to 150 millisecond, and guideline-directed medical treatment. There was some exclusion criteria: intrinsic QRS with LBB morphology, because it requires, of course, CRT implantation, severe renal dysfunction, severe right ventricular dilatation, and acute coronary syndrome or revascularization prior 3 months. Altogether, 360 patients were randomized to CRT-D or ICD arm in a 3:2 ratio, and the composite primary endpoint was the first occurrence of heart failure hospitalization, all-cause mortality, or less than 15% reduction of left ventricular end systolic volume from baseline to 12 months, means lacking reverse remodeling. The secondary endpoints were composite endpoint of heart failure hospitalization and all-cause mortality alone, and left ventricular end diastolic volume and left ventricular ejection fraction changes.
Interesting. And you, I'm assuming this patient already been on guideline-directed medical therapy in both arms.
Yeah, that's true. Over 96% of the patient had RB or AC inhibitor or ARNI, and 93% had beta blocker, and 63% was treated with mineralocorticoid antagonist, which demonstrating a very, very clear and good heart failure treatment. This study was actually performed between 2014 and 2022. And during this period, SGLT2 inhibition was actually not recommended according to the guidelines.
Good point. That's what was next question. Thank you so much for clarifying. So let's go to the result of the trial.
So the results. First of all, I have a short message about patient characteristics, because the results is very much depending on patient characteristics. The patients were older. Males were overrepresented compared to other de novo cardiac resynchronization therapy study population. Severe heart failure symptoms could be observed in more than half of the patient. That means New York Heart 3, 4A, with a relatively frequent ischemic etiology around 60%, which is typical for Central Eastern Europe, because this study was actually performed in 7 Central Eastern European countries. The proportion of patients with a history of current atrial fibrillation was 54 and 60% respectively. 1/4 of the patient had prior major ventricular arrhythmia, and half of the patient had a previous heart failure hospitalization. The mean left ventricular ejection fraction was 25%, and 2/3 of the patient had prior pacemaker implantation, and with a very high 85 to 88% right ventricular pacing rate, demonstrating a clear desynchrony. So this is a very sick patient population.
Sick, very sick. Yeah, very sick. Especially with the mean of 25% ejection fraction is half of your population. That's pretty sick too, and tough to recruit and manage.
Yeah, this is not a mild heart failure population, because if you go back in the past, the MEDIT CRT trial was a mild heart failure patient population in which CRT demonstrated the benefit. So let's go to the primary endpoint, which is all-cause mortality, heart failure, hospitalization, and less than 15% and end-systolic volume decrease. So this is very interesting because we had the baseline echo, and of course, at the end of the study, at the end of the follow-up and another echo, we had continuous reporting hospitalization and mortality. So we can we also have data at 6 months, which are demonstrating substantial difference regarding all-cause mortality or heart failure hospitalization between the two arms. But at the end of the study, during a median of 12.4 months, the primary outcome occurred in 101 out of 128. That means 79% of the patient in the ICD group, and 58 out of 179, that means 32%, in the CRT-D group. The odds ratio was 0.11 with a very good number needed to treat, which was 2.2. So there is a need for treatment of 2.2 patient, and we can actually eliminate one primary endpoint. The composite endpoint consists of 2 time to event and 1 binary outcome. That means echo at baseline and echo at the end of the study. That's why we had odds ratio for primary results. But if you look at the very often used all-cause mortality or heart failure hospitalization, in this composite endpoint, CRT-D showed markedly significant benefit compared to ICD alone, with an adjusted hazard ratio of 0.27. The number needed to treat is 4.7. This data is mostly driven by heart failure hospitalization. Regarding all-cause mortality, there was not statistically significant difference between the two groups. However, this study was not powered for mortality. At the same time, the risk of heart failure hospitalization was significantly decreased in the CRT group compared to ICD. So that's why the primary endpoint mostly driven by heart failure hospitalization and the significant reverse remodeling demonstrated by echo. And we also had secondary endpoints. We also analyzed, first of all, the primary endpoints in pre-specified subgroup. And it was very interesting that the beneficial effect of CRT-D upgrade was absolutely consistent and homogeneous across all pre-specified subgroups regarding age, percent of right ventricle pacing at enrollment, baseline left ventricle ejection fraction, atrial fibrillation or flutter and enrollment, history of ischemic events or diabetes mellitus, New York Heart Association class, NT-proBNP at enrollment, EGFR or BMI at enrollment, which is a very important message. But just go back to the echocardiographic response. Left ventricle end systolic volume is a component of the primary endpoint, and left ventricle ejection fraction and left ventricle end diastolic volume, they were secondary endpoint, were remarkably improved from baseline up to 12 months, demonstrating significant reverse remodeling in the CRT-D arm as compared to ICD. The difference between the two arms at 12 months in left ventricle ejection fraction was almost 10% in absolute value, and the difference at 12 months in left ventricle end diastolic volume was 39 milliliter. The safety outcomes also showed very high success rate of implantation procedure with 98% in the CRT-D and 100% in the ICD group, respectively. We observed a low incidence of procedure or device-related serious adverse event, 12% in CRT-D and 7.8% in ICD arm. But very interesting, the occurrence of life-threatening malignant ventricular arrhythmias was substantially lower in the CRT-D arm compared to ICD. That means 1 out of 215 in the CRT-D and 21 out of 145, 0.5 versus 14.5, demonstrating that reverse remodeling associated with a significantly reduced number of life-threatening arrhythmias. So this was the very short, these were actually the very short results demonstrating the clear benefit of CRT-D upgrade compared to ICD alone.
That's very, very interesting indeed, and especially as you mentioned, the hard outpoint or the primary endpoint of heart failure, but you're also decreasing the incidence of lethal or malignant arrhythmias as well. So, how do you think, Dr. Merkely, this is going to change or impact the guideline going forward to manage this cohort of patients?
That's very interesting. Just to summarize what happened after implanting an additional lead into the left branch of the coronary sinus. So, in patients with HFrEF and significant right ventricular pacing burden, CRT-D upgrade compared to ICD only treatment reduced the composite primary endpoint of heart failure hospitalization, death, and absence of reverse remodeling. Fewer hospitalizations for heart failure or reduced all-cause mortality favored CRT-D, which was accompanied by improved left ventricular reverse remodeling compared to ICD alone. Moreover, the incidence of VT-VF events were significantly lower in CRT-D patient compared to ICD alone. So in general, CRT-D upgrade proved to be a safe procedure in this sick patient population in experienced high-volume centers. So overall, HFrEF patient with a pacemaker or ICD should be strictly followed in the clinical practice in those with intermittent or permanent right ventricular pacing. And CRT upgrade should be performed immediately without postponing the procedure to a later date to avoid and reduce the risk of and further adverse events such as mortality, heart failure, hospitalization of left ventricular remodeling. And I think the guideline will change, and the class and level of evidence will be for sure 1A or 1B to prevent a heart failure, hospitalization, and of course achieve significant reverse remodeling. I'm pretty sure the results are so robust just to demonstrate the efficacy and also a safe procedure because it's not associated with procedure-related complication.
Well, Professor Merkley, really appreciate your time and congratulations for a well done and executed trial that definitely going to change the way we treat as well as prevent patients with heart failure, advanced heart failure, very sick population, to with readmission, which is a big burden financial on the health system as well as on the patient. And congratulations for a well done trial. Appreciate your time. And for all our viewers and listeners, thank you for being with us. Please follow the Cardiology Update social media outlets on LinkedIn, Instagram, Facebook, as well as Twitter for any update in cardiology. I am Chadi Alraies from Detroit Medical Center in Detroit. Thank you for being with us.